My name's Leanne. I'm a vascular nurse consultant up at Yorkshire, hence the dulcet tones. I'm a doctor but by PhD. I'm not an MD, and I've come to talk to you today about going beyond the ABPI. When you talk about the ABPI, the ankle brachial pressure index, you know this is your bread and butter. You know that it's actually embedded within clinical policies, within every single national guideline that you've ever read. You know that it identifies peripheral arterial disease, but actually it's the key to the door, isn't it, for compression therapy? And that's where we currently stand. But I think there's a bit of a problem with only having that key to that door. And I think that the Julian guest that's been to speak to you earlier on today really amplifies this. If you look at the burden of wound care that we've got throughout the UK at this moment in time, this is a bit untenable. We cannot carry on with this situation. It's costing the NHS £5.3 billion every single year. And the difficulty with that is this is increasing year on year, spend on spend. And if we don't stop, we are going to be in serious trouble. The NHS hasn't got an infinite amount of money, and there certainly isn't an infinite amount of resource in terms of staffing. But there's some really huge issues for me as a clinical academic, that when you actually look at the research evidence says for a venous leg ulcer, we should be able to get healing at 70% between 12 and 16 weeks, and you should be able to get 98% healing at 24 weeks. So therefore, on your books, you should only have 2% of wounds that's been there over 24 weeks. Does that feel real? No, if anything, it feels completely and utterly the opposite of that. And actually, the real life data that comes, not from the research, but actually from real life studies in terms of prevalence, is that we've got healing rates as low as 9% at 6 months. And these are simple venous leg ulcers. These aren't your complex leg ulcers. These aren't your mixed disease leg ulcers or your arterial ulcers. These are venous leg ulcers where we know what evidence-based care these patients should be having. And even though we've got all of that fantastic knowledge, we're only getting 47% of our patients healed at 12 months. Now, if we're doing that, so next year you've got a whole new caseload and your 50% legacy. The year after, you've got your 50% legacy and the 50% legacy from the year before and your new caseload. How many years till your services become completely and utterly unsustainable? And I think actually in the NHS, we're about at that cliff point right now. But the problem is with all of this, is that we all recognise that things could be very, very different. And actually the reason why we're in the terrible situation that we are in currently is this unwanted variation. There is so many variations throughout the NHS. Remember what the NHS is? It's supposed to be a national health service. It's anything but that, if you ask me. We have problems in terms of the under-recognition of an ulcer. It can be a skin tear for 12 weeks. It could be a dehisced surgical wound for 6 months. Nobody identifies if it's on a lower limb that should be treated as an ulcer. I also hate the word ulceration because I think that it's a real barrier in terms of patients. How many patients have said to you, it's not an ulcer, is it? They're scared to death of that diagnosis. And obviously, if there's a degree of fear, there's a degree of a delay of presentation. And maybe we should be just talking about lower limb wounds rather than ulceration. We've got huge problems in terms of poor assessment and no diagnosis. Many nurses will diagnose a UTI in a heartbeat, but for some reason the nursing fraternity finds it really difficult to say that is a venous leg ulcer. But without a diagnosis, how do you know whether to face east in terms of compression therapy or west in terms of revascularisation? And even if we get all of that right, we've got a huge problem with the underuse of evidence-based practice. ABPI, 16% of patients have it within 6 weeks. 16%. 84% of patients don't get an ABPI within 6 weeks. Compression therapy is not used where it should be used. Venous intervention, a curative approach to venous hypertension, is not offered to all of our patients. We have the overuse of ineffective therapies. Look at the spend of reduced compression, modified compression. If it's not 40 milligrams of mercury, you are tickling the leg. You are wasting your time. And additionally to that, we have a problem within this National Healthcare Services in terms of the variation of commissioning. How can you get access to your vascular service? Have you even got a lymphedema service? Have you actually got a leg service? There is huge variations, and all of that gets us the problems that we're currently facing. But I think you guys, the Leg Club, are really good at this. This is where you absolutely excel more than any other NHS service, I think. You really know how this feels from a patient point of view, and you really put this patient into the heart of everything that you do. This is Tracy. She's my fabulous patient. She's now turned 40. She's had a leg ulcer for 15 years of her life. And I just want to spend 2 minutes just reminding us all why we're here. These are her words. I'm upset about the life I could have had, the career I should have had, and the person I should have been. I always thought I would be somebody and achieve something in life, but I feel I've had that opportunity stolen away. I hate feeling self-conscious, disabled and unattractive. I hate this leg ulcer has taken away my self-confidence. And I think when you read her words, we have to take an army of clinicians to solve this problem. We know what we should be doing, and we need to be banging that drum to getting it right. But there is a huge problem, because when we talk about getting it right, it's embedded in the ABPI, isn't it? It's embedded in that appropriate assessment. You know how to diagnose a leg ulcer. It comes with these factors. You start by that detailed patient history. You look at their vascular risk factors. You examine that patient, that limb, that wound. You look at how that ulcer presented. But within that, you're also wanting to do an ABPI. But remember, an ABPI will never confirm venous disease. All an ABPI is really assessing that patient's suitability for compression therapy. I love this slide because I think everybody who's dealing with venous leg ulcers has to realise that you've got to view a leg ulcer as a weed. It's not a wound, it's a weed. Because actually the roots of this wound is within that venous system. You have to remember that behind that wound is chaos. There is chaos of chronic inflammation caused by venous hypertension. And if you don't tackle that underlying chaos, you will never get these wounds to heal. You would never go along and cut a dandelion's head off on a weekly basis. You'd actually dig out the weeds. You would attack the weeds, and that's what we need to do with leg ulcer care. We need to turn that unfavourable, chaotic, chronic inflamed condition into a favourable condition to get these wounds to heal. And we do that by compression therapy and venous intervention if appropriate. We can fanny all we like in terms of wound bed preparation, but without appropriate compression, these wounds are never going to heal. So when should an ABPI be performed? Well, we used to talk about 6 to 8 weeks, didn't we? At some places, we used to talk about 3 months. The National Wound Care Strategy that I'm chairing the lower limb stream on have actually really emphasised that this needs to be treated like a cancer. It's an urgent thing. We need to be doing ABPIs within 2 weeks of presentation of every single wound. That's the service you'd want, isn't it, if you had a wound on your lower leg? So why shouldn't we set their goals that high? We should also do it if any patient presents with a pressure ulcer of the heel or any other type of heel wound. It should also be done on every non-progressing wound. Get rid of that time factor of I've got to do an ABPI every 3 months. If the wound's non-progressing, think about repeating that ABPI. Because timely diagnosis improves outcomes. We know that. You know what an ABPI is. It's one of the first skills that you're taught when you become interested in leg ulcers. It's a fantastic, easy bedside test. There are a few myths with an ABPI, though. There's a myth that you can't have an ABPI when you've got a DVT. Yes, you can. There's no risk whatsoever of you moving that clot within that venous system. No risk whatsoever. That comes from the old teaching, if you remember, when you had a patient on a DVT with a ward, they weren't even allowed to use a commode. Because can you remember what was going to happen if that patient stood off that bed to use that commode? They'd have a PE and die, wouldn't they? That's what we're all trained. And that's why this myth's come from. We ambulate all our patients with DVT now. There is no risk in terms of doing an ABPI. Doing an ABPI if you're not in a supine position is pointless. You are going to give yourself unjustified readings. We do need to be careful if patients aren't able to tolerate this. But what do you do if you've got a patient who can't tolerate it, who cannot lay down? There are many factors that influence the ABPI. It's not the panacea of assessment. It's not going to give you every single bit of reassurance that you want from it. There are many things that will impact on your ABPI. My favourite one is Vascular Clinic, is using lubricating gel. to do an ABPI, because that's all that's on the side, because it's colorectal clinic before we get in. So we'll just use that lubrication gel. What are we doing? You know what this is about, and there are a few changes in terms of automated machines and whether you need to do one arm or two arms with the ABPI. Can I just emphasise, as a vascular nurse consultant, you need to do both arms. Because if you do an ABPI that looks like that, using the right pressure of the arm or the wrong pressure of the arm can make a significant difference to your reading. Subclavian disease exists. You need to do both arms to ensure that you've got an appropriate ABPI. You can trust an ABPI when it's low. It's probably going to be accurate, but you can't trust it once it gets high. So, what do you do in your clinics if you've got an ABPI that's 1.4? That's 1.5. What do you do? Because at the moment, policies and guidelines say you can't compress them. Where do you stand as a clinical nurse? Well, the reason of doing the ABPI is this. It's to detect that underlying peripheral arterial disease. In a patient like this with significant inflow disease, SFA disease, that patient's going to have symptoms that will instantly make you, I want to say twitch your bum, but I don't think that's appropriate. They'll instantly make you consider. So this patient's probably got an ischemic-ish looking leg with an ulcer that's looking a bit more arterial than venous. You'll probably smell that one out straight away. But your ABPI is to protect you from this occult iliac disease, which may actually impact on their flow, and that ulcer is presenting as a typical venous leg ulcer, but you're wanting to determine how much compression is safe to put on. So I'm not saying the ABPI is pointless, I'm just saying it may not be the panacea that we're currently saying. Because what do you do if your ABPI is 1.4? Do you have to refer at this moment in time? You're all leg nurses, aren't you? So you should all be really good at leg assessment, would you say? Okay, I'd like you to label that diagram, please. Why can't you? Should you be able to? I would argue, of course you should be able to. This is a fundamental aspect of leg ulcer care. I would encourage you all to take that extra education so you can put the names on all of that diagram, so you can label those arteries. Because if we're writing back to you as a vascular firm to say they've had SFA intervention and a little bit of intervention of the left common iliac, what does that mean? You need to be able to translate that for two reasons. For your clinical judgment, but also for your communication to that patient. Nurses are much better at communicating with patients than any vascular consultant I've ever met. Even you. So the reason behind all of this is that we just have to step back. And I don't mean to be condescending, but I just want to teach you a little bit of A&P again, just to go back. Can we remember what an artery is? Can we remember that the artery has got 3 walls within it, yeah? The intima, the media, and the adventasia where the connective tissue sits. But I want you to picture this in your mind whenever you're seeing a patient with a wound. We look quite often at the venous disease, and we also need to consider the arterial flow, but this needs to be linked with the capillary bed. You see edema in most of your patients, and this is the reason why. Those green things that's linking through are your lymphatic, so it's no surprise that you get edema both with arterial disease and with venous disease, because this is an interlinking service within the middle. When you talk about arterial disease, it starts to form within the media, within the middle lining. It starts by making a chronic inflamed reaction, and those chronic inflamed reactions starts to bring in white cells. As the white cells start to absorb all the cholesterol, they become like marshmallow size cells, and they're called foam cells. And within that, they then start to cause more chronic inflammation and more problems in terms of pulling in lipids and foam cells. And over time, it starts to protrude within the lumen of the artery. And you've seen this slide, you've seen it happening on the cigarette adverts where it all used to drip out. That's exactly what it looks like when you operate on it. But the problem is once it gets to a degree, it can cause us significant problems. And these are the problems that patients have faced when it comes to lower limb disease. You'll have heard the term intermittent claudication, but do you know how to diagnose that? Do you know what we do in terms of vascular? We've only got about 5 questions that we ask a patient to make that decision of have you got claudication or not. It can be you can do this, you can become specialised in this area. It can progress to rest pain and tissue loss. But the difficulty is that there is 8% of patients out there who have asymptomatic peripheral arterial disease. So no symptoms whatsoever. They don't know they have this disease. They could be presenting with a venous leg ulcer. And that's where you need your Miss Marple diagnosis skill set to be able to assess those patients completely, which may include an ABPI, but may not. So let's talk about intermittent claudication for 2 seconds. This is dead easy to diagnose. There's something called the Edinburgh Risk Score of intermittent claudication. It's a questionnaire. You tick some boxes, yes or no, and it'll determine whether you've got arterial disease or not. Intermittent claudication predominantly happens in the calf. It can happen in the thigh or the buttocks, but predominantly in the calf. Patients say that they can walk 100 yards. They get a cramping tight, vice-like pain around their calf that forces them to stop. If they stop, it starts to relieve over time as the oxygen perfusion increases. If they start walking again, it returns. It only ever happens on exercise. If patients are saying they get the pain when they're stood up, washing the sink, doing their ironing, it's not intermittent claudication. It always relieves with a short period of exercise. If it doesn't, it's not due to intermittent claudication. So there's some great, easy diagnostics tools that you can have in your mind of how to assess these patients. Many of you may know patients with peripheral arterial disease that you've actually referred into a vascular centre and we've decided to do nothing with. And the reason why is that Mother Nature is fantastic. First off, she's female by nature, so therefore brilliant at what she does. You can see what's happening here. This patient's got a blockage, a complete occlusion with the superficial femoral artery, and you can see the new growth of collateralization around it. And that's why many patients with intermittent claudication, we don't do anything with. We just wait over time, encourage exercise, reduce the risk factors, and over time, they should be able to improve. Unfortunately, 1% of our patients, though, go on to assess in terms of critical limb ischemia. If you see a foot like this, you can see it's red towards the end. There are many patients that we see that's had a course of flucloxacillin because of this redness. If you are considering whether a patient has got an infection on their foot or whether it's due to ischemia, simply elevate that foot. Elevate it up to hip height. If the redness doesn't disappear, it's probably due to infection. If the redness does disappear, it's because of arterial flushing. So therefore, it's because of peripheral arterial disease. That patient does not need antibiotics. So there's great wins with this. Rest pain happens every single night. It's not Monday, Tuesday, Friday. It's every single night. And the patient will report to you that I can go to bed okay, and I wake up with horrendous pain in my foot. Horrendous pain that means I've got to get out of bed, dangle my foot on the end of the bed, or walk around. And it happens every single night. And again, there are some great tools in terms of how to diagnose this. But unfortunately, we still get this. We still get significant peripheral arterial disease. And unfortunately, when patients present at this level, we're left with very little options but to amputate, major limb amputation. So we need to all get better at recognising this disease earlier. And there are many patients within leg ulcer services that present to you with critical limb ischemia. Many of them you will have seen in your services. So what are you going to do differently from tomorrow onwards? Well, hopefully you'll all become little mini-vascular nurses. That's what I hope at the end of this. Because I want you to add other things to your assessment than you are currently doing. I want you to take a comprehensive history looking at arterial risk factors. I want you to consider feeling foot pulses. I want you to think about wave formations. I want you to think about when you're going to do an ABPI or a toe pressure and what you're going to do if you can't get any of those. When we talk about palpation, this is what vascular do more than anything. We hardly ever do ABPIs. We actually just feel. I'd encourage you all to feel. Feel the foot pulses. Do you assess popliteal pulses on a regular basis? If not, why not? Get skilled in it. You could become champions in this remit. Before you do any type of assessment, you should be assessing, is that pulse palpable or not? If you can swear that that pulse is palpable, the chances of them having arterial disease is tiny. It's a great indication. If you've got a patient with an ABPI of 1.5, if you can feel a foot pulse, that patient's going to be safe for compression. The ABPI is a good tool, I'm not saying it's not, but it's not the panacea of everything. It's great at detecting large vascular disease, but it's really poor at detecting microvascular disease. It is quick and easy, but we can often get falsely high elevated pressures, and I just want you to be wary of them. Wave formations are great, because you becoming good at and competent at and confident at detecting the difference between monophasic, biphasic and triphasic is useful in your clinical sphere. There is a great teaching package that's been wrote by Andrew Sharp at the University of Huddersfield. Within that there are 50 waveforms and 50 sounds and 50 clinical diagnosis. So you can go home, put it on YouTube, and you can listen to a sound wave and you can get a bet whether that's a monophasic, a biphasic or a triphasic. It's a great tool for you to become competent and confident in this sphere. How many of you do toe pressures? Yeah, they can be more useful than an ABPI. They're certainly more reliable. My issue with the toe pressure is that we have no definitive. With the ABPI, we've got a definitive of 0.8 to 1.3. There is no true definitive within the toe pressures. There is changeable between whether what is diagnosed as normal, what is diagnosed as peripheral arterial disease. But I just want to finish on you thinking about what are we currently doing. Because I can show you a number of studies where we are using full strength compression in patients with ABPIs of 0.5 to 0.6. In fact, there's an additional paper that's just been presented of pure arterial wounds having full strength compression on them with benefits. You are all nervous about putting compression on of the fact that you will do what? You'll cause ischemia. That's what you're worried about, isn't it? That's what you're cautious about. We only advise reduced compression if you've got an ABPI of 0.5 to 0.8. Remember, the chance of your compression bandage actually causing occlusion of the artery is extremely thin indeed. To me, should it be more about sensation check? Can you feel if this bandage is going to be too tight on you? If you can you remove that bandage? We need to be protecting the vulnerable areas to prevent bandage damage like this. And actually we see more damage through bandaging and poor bandaging than we do through inappropriate bandaging on the wrong type of patient with arterial disease. The benefits of compression is massive. Remember that compression will help to solve your venous insufficiency. It will help to manage your edema that you've got, but also it will help with your arterial flow, because if you're reducing the pressure around the capillaries, you actually give that artery more options in terms of getting flow down there. You're all scared of this. This is what you're fearful about. But I've only seen this in my 15 years of a vascular nurse. I've seen damage due to compression therapy in patients with arterial disease only 3 times. Only 3 times. But I see this every day. I see damage, harm done to patients by no compression. We've all gone a little bit mad. We're also scared of not putting compression on when you haven't got that most appropriate arterial assessment, so we shouldn't do that. But we forget about the risk. The risk of doing nothing and not applying compression to these patients is actually bigger. You will see this every day in your clinical practice. Wet legs. There is no such diagnosis of a wet leg. It's probably a leg that just needs some compression therapy putting on. So I would say that actually we need to turn this all on its head. The ABPI only needs to be part of your assessment, but you need to use the whole of your wider skill set, because we know we've got a window of opportunity to heal these wounds. We've got a 10% chance of healing if that wound's been there for more than 6 months. So we need to get this right within that first 6 months to be able to improve patients. Delaying harm and being more cautious is actually will cause your patients more prolonged healing. The BLS have produced a fantastic document to help you along these ways. This position statement, I think, is a real game changer. It helps you to say how you can go beyond an ABPI, what you can do if you can't lie that patient down, you can't completely occlude the arteries, you cannot do an ABPI because that patient finds it too uncomfortable. And within that, there is a fantastic risk assessment tool that you're able to do. I would love a world where we no longer do ABPIs. That's my panacea. I'd love to ask Naz when was the last time he did an ABPI on a patient with a venous leg ulcer, and I can imagine his answer is never. He will feel with his fingers, he will look and he'll diagnose that that's a venous leg ulcer and that patient can have full strength compression. My vascular consultants do not do ABPIs. I don't do ABPIs for venous leg ulcers. But all of a sudden we're asking you, this is the only option. What I would say is I would love a world where we are safely checking patients. What are your risk factors? If you're a 40-year-old woman who's got a presenting venous leg ulcer, who's never smoked in her life and not a diabetic, what's your chance of getting peripheral arterial disease? So therefore, should we rationalise things with more of a risk assessment tool of peripheral arterial disease and basically classify that as, if you've got intact sensation at the end of the day, what is the risk? The risk is probably nothing. But when I say all of that, I know in back of my head, I am being a bit maverick. And what we need actually is we need a validated risk assessment tool for this to replace the ABPI. And that's what's hopefully will be coming in the near future. So what I'd like to say is, yes, use your ABPI, but become slightly better. Become leg ulcer champions. You are at the heart of patient focus in everything that you do. You can become excellent at this. There is more harm from doing nothing than getting this wrong. Thank you very much.